Assalamu alaikum. I would like to thank Dr. Hiba, Dr. Malak, and all the organizing committee or Rabtat al-Kuwait for inviting me. We will continue the IBD session. Our next talk will be delivered by an expert in IBD, Prof. Shaji Sebastian. He is a professor and consultant gastroenterology at IBD unit at Hull, UK. He is also an ECCO governor board member. He's a well-known figure in IBD with multiple research. He will tell us, and his talk will be about therapies in IBD, very important and hot topic. Insight from ECCO guideline about first line and sequencing. Thank you. Please stick to the time, Prof. Sebastian. You have 20 minutes.
Thank you for the kind invitation. Thanks, Heba. It's really a pleasure, and I'm just arrived about an hour ago, and seeing all the energy in the audience and the meeting is really, encouraging for me as an IBD clinician involved with ECCO. So I do have a conflict of interest because the title is about ECCO guidelines, and I am actually associated with ECCO for many years and currently in the governing board. The rest of my conflicts are there. So before I talk about guidelines, I just want to bring this back to who matters most, which is our patients. So I want to talk a little bit about our goals in the treatment of IBD. And then we talk about guidelines. Particularly guidelines in relation to choosing therapies. I want to introduce some challenges which we may have, and that will frame why we have taken a slightly different approach in relation to the latest ECCO guidelines on Crohn's disease, and then we'll bring it back to the patient to somewhat personalize that therapeutic approach. So let me start with what matters most. It's the patients. Now, if you actually look at this figure, you can see we are more and more at conferences talking about remission, endoscopic remission, even histological remission, even disease clearance. So that's what we are mostly talking about. But if you actually talk to a patient, their focus is just to feel normal. They definitely don't want to be hospitalized, or have surgery. But equally importantly, they simply want to be living a good life, staying alive without fatigue, without depression, without the effects of a chronic and currently incurable disease. But there are some areas where our goals meet. For example, this study from David Rubin, essentially a survey, large survey of both Crohn's and ulcerative colitis patients and their physicians. And you can see the main drivers for the treatment choice almost is the same for physicians, Crohn's disease patients, and UC patients, because they just want to remain well, i.e. they need to have a durable response, which is the main priority. So we meet in the middle. So in my clinic, I usually start with this question, whether it's a new patient or a follow-up. What's your number one concern relating to your IBD? That could be just symptoms, or it could be worry about the future of a young person who wants to pursue a career, go to university, or a young woman who wants to have a family starting. So whatever is it, what's your number one concern and priority? And that allows us to think about the treatments, because we should be all proud as an IBD community that we have got numerous treatments available now over the last 10 decades. To such an extent, you can in fact actually have a red carpet of various treatments what has come through. So I grew up with the original studies of infliximab. Now you can see that there are numerous drugs, both biologics and small molecules. And even those who are in the field by these multiple choices are actually confused what to use. So it's almost like finding a partner for a dance in relation to choosing a drug, particularly the first advanced therapy drug. Because we have a disease which is very heterogeneous. I always talk about the 6,000 odd patients I have in my unit are 6,000 different diseases. We always try and clump them into two: Crohn's, ulcerative colitis, and maybe IBDU, but they all have individual characteristics with heterogeneity. And one way of differentiating various treatment modalities would be head-to-head studies, but they do have problems. I'll show you one problem. And then we keep hearing about precision approaches, but they are really not ready for prime time. So head-to-head studies. This is a head-to-head study of what we all heard of, what's called the VARSITY study, which compared vedolizumab and adalimumab in moderately active UC patients. Now, vedolizumab came out trumps there, but we were really comparing apples and oranges. And if I have to be not connected to any particular pharma, I would compare vedolizumab with infliximab. And even if I am comparing with adalimumab, I would add dose optimization and immunomodulation. None of these was there in VARSITY. But a better one was in Crohn's disease, which is the SeaView trial, where adalimumab and ustekinumab was almost identical in relation to their efficacy. And then we heard about precision medicine. Is it really ready for prime time? I have been hearing about precision medicine for a number of years. It's almost like something what you always think of as a mythical creature. So this is in Scotland, this Loch Ness monster. Nobody has actually seen it, but we are always talking about it, and many reviews are actually being written, but we are nowhere near precision medicine. And then we go to network meta-analysis. We keep hearing about, can they help us in choosing our therapies? But they do have a number of issues. They are only limited to trial data. And actually more than 50% of our patients do not fit into the inclusion and exclusion criteria for the licensing trials. There are various study designs, different endpoints, populations, and patient characteristics. Even the drugs have different characteristics, and also we are also not thinking about the long era of advanced therapies, which is since at least late 90s. There are major problems also with meta-analysis in terms of using them in guidelines. So I was at a meeting last night in the UK when we were debating whether we should really use network meta-analysis as a tool in evaluate different drug options. And you can see from the response of this is predominantly IBD audience, they actually disagree that it should be used. But most of the guidelines now use network meta-analysis. So with that background, I want to talk about multiple ECCO guidelines which has been produced. But the last one, we have taken a slightly different approach. And I just want to give you a couple of quotes from this editorial which Tim and colleagues who led this particular guideline said. The first thing on the left, with the current data available, we were largely unable to determine a clear evidence-based statement to position specific drug. Remember that word positioning, you hear that in all meetings. But they couldn't come to any conclusion about positioning drugs. And they also clearly said that bearing in mind the degree of equipoise relating to comparison of therapeutic approaches, we have to individualize the approach using those characteristics such as disease phenotype, safety, patient preference, and cost. That different approach is actually recognized in the current ECCO guidelines, and we have said that NMAs were not sufficient basis for formulation or specific positioning. We have used grade methodology, and we've also added some practice point, bringing back to the patient whom I talked about earlier. It is also a multi-professional approach, included patients in the process, and we really need to get that sort of approach in future guidelines. We also moved away from some of the terms what we keep hearing about. The drug should be considered by merit and not sequenced as conventional or advanced. What is a conventional treatment which was 20 years ago may be different to now. What is advanced therapy now may be different in 10 years' time. So, based on this simple, straightforward table gives pretty much what was in the Crohn's guidelines. It talks about what is recommended, what can be considered and what is not recommended. And I want to go through one or two of them. You can see systemic corticosteroids are used for induction, but not for maintenance. That's a good practice. Similarly, thiopurine monotherapy for induction was not recommended, but perhaps it has got some role in maintenance. And when it comes to the biologics and small molecules, all of them are of similar efficacy almost in relation to induction and maintenance, and they are all recommended. Then I want to deep dive into one or two areas which may be more of practical relevance. Even in my unit, until about 10 years ago, we were using 5-ASAs in Crohn's disease. And I think this is the end of the road for 5-ASAs in Crohn's disease, both in induction as well as in maintenance, as it has come up with strong recommendation with 100% consensus. And what about the debate about combo versus monotherapy with anti-TNF? And with infliximab, combination therapy with thiopurine when starting induction has been recommended with strong recommendation and a moderate quality evidence. But the duration of this combination therapy is minimum 6 to 12 months. And even ECCO, this guideline also go ahead and says that there is an opportunity to de-escalate combination therapy to anti-TNF monotherapy and maybe even withdrawal of thiopurines after this 6 to 12 months period. As opposed to that, adalimumab monotherapy has been proposed both in induction as well as in maintenance. What about the monitoring? ECCO says insufficient evidence to recommend proactive therapeutic drug monitoring compared to reactive or even standard of care, because the overall evidence for proactive monitoring is somewhat limited. However, therapeutic drug monitoring may be used when optimizing dose in patients treated with anti-TNF therapy. Then comes to the wording of sequencing, a word which I do not particularly like because I do not think we have sufficient data to actually say what should be the sequence as evidenced in the ECCO consensus. So it says currently there is insufficient evidence to direct how advanced therapies should be positioned. And what about combo advanced therapies, because we have a group of patients who are multi-drug refractory, particularly in the Crohn's setting. And in this case, along with extraintestinal manifestation, there may be a role for combo advanced therapies and also in some refractory Crohn's disease. And there are a number of trials on the way on this matter. Then finally, bringing back to our own patients. Patients with special situations, those who are planning to be pregnant, those who have previously failed one agent such as anti-TNF, those who have got some lifestyle considerations, the important things what matters to patient, such as a business person who travels often for work, you would want to tailor therapy, and then in perianal disease. I wouldn't show this slide, although it is not included in the Crohn's guidelines, but because I believe that this is probably the most transformational trial in the IBD field in the last few years, which is the profile study from the UK, which has conclusively shown that we need to start treatment in our IBD patients, in our Crohn's patients earlier. What about UC? Unfortunately, the ECCO guidelines on UC are somewhat outdated. The new guidelines, some from this country are already involved in the 2025 guidelines, which is just started. So I'm going to just give you some personal perspectives. First thing is about treatment goals. I do believe that sometimes perfection can be the enemy of good. And if you look at what our goals have been, we have progressively stepped up our goals from 2015 up to the latest STRIDE guidelines. But 2015 guidelines were primarily designed as a research tool. But now we talk about actually achieving histological healing as our treatment goal. I'm not sure we are there yet. Because while there are many options in ulcerative colitis, what it comes down to is still the patient. What are the factors which lead us to choose that first-line therapy? Is it the efficacy? safety profile, then individual characteristics, and also disease characteristics. I have narrated some of the things what I use when I see a patient, when I think about what is probably the better option in conjunction with the patient's choice. I will show you only one NMA, which is this, and I want to show you why I do think that NMA should not be used in guidelines. So this is an NMA which is conducted by our colleagues in the UK, which suggested that upadacitinib is fantastic. It's the best one for ulcerative colitis. But there are some inconsistencies, sweet hotspots there. Can you see filgotinib? It's actually well below the 0.5 threshold. It's the same JAK1 selective inhibitor. In fact, actually, there is more filgotinib used in practice in the UK compared to upadacitinib. But I do like this NMA, which was conducted by one of your own colleagues who is sitting in the audience. Now, he showed in his original meta-analysis that upadacitinib and risankizumab are the top front runners. But I like this one particularly. This is bringing back to the patient. Here, he looked at patient-reported outcomes. And you can see that in this case, the sweet spot what I showed you earlier, sorry, where is that gone? Okay. The sweet spot what I showed you earlier with regard to filgotinib and upadacitinib is actually no longer there. But I do feel that the good old anti-TNF is still the king of the hill with regard to IBD therapies. Primarily because introduction of biosimilars have been a game changer. It has brought access to patients across the world and also made therapies much more affordable. I think the slides are frozen. Okay, let's go. Okay, so what happens when we actually fail anti-TNFs? We can use any of them. It is all down to that decision grid I showed you about the various factors, patient and disease-related factors. We also have to remember in ulcerative colitis, surgery remains a valid option, an option on the table at each and every encounter. We may have some pulls and pushes in relation to treatment choice. For example, pulls of extraintestinal manifestations. If somebody has got plaque psoriasis, I may consider more of a P19 agent, risankizumab, guselkumab, or ustekinumab. All of those have got good efficacy in psoriatic patients. Or if somebody has got spondyloarthritis, my drug of choice there will be anti-TNF, although there are now data emerging for JAK kinase inhibitors. And if somebody has got multiple sclerosis, S1P modulator are the drug of choice because they have been used in multiple sclerosis for a number of years. And there may be some pushes which may let us not use certain drugs such as JAK kinase inhibitors in over the age of 65 or those who have significant risk of major cardiovascular adverse events, or the anti-TNF agents with significant heart disease or malignancies, or things such as anti-integrins with active tuberculosis. So when I choose therapies for extraintestinal manifestations, I use this decision grid. Anti-TNF here again remains the king of the hill for vast majority of extraintestinal manifestations. But you can see JAK kinase inhibitors also have a role in majority of them, perhaps not much data on uveitis. And when I see a particular patient, such as this on the left-hand side with psoriasis, or on the right-hand side uveitis, I probably give that as the first option to the patient. But we also have to know that we need to involve our colleagues from rheumatology, ophthalmology, or dermatology in this case. And I just want to finish by thinking about what is realistic for our patient in front of you. I talked about stride a little bit earlier. I do think that we should be at the realistic space at the moment. If you think about worldwide IBD care, think about what matters to patients, which is the patient-reported outcome, which as Shahab showed on his meta-analysis, that we have drugs which are available now, which we can achieve remission in a significant proportion. But aspirational targets, such as histological healing, may come in future, but at the moment, I do think they are still very much aspirational. And bringing back to my patient, when I consider choosing any advanced therapy, first of all, we have to start the advanced therapy, effective therapy, early in the appropriate patient. We have to think about whether that first therapy which you are going to start is going to have longevity, i.e., is that be your partner forever. We want to protect some drugs, particularly anti-TNFs, so that they don't develop immunogenicity and we can continue them for the period of time it is working. So we have to think both short and long term. Short term particularly to get the patient on board, get them back to work, get them to enjoy their things, and then develop that partnership to use your therapy long term. And then consider various determinants of choice such as the special phenotypes, durability, and cost. But we have to finally remember that inadequate treatment of patients with IBD is perhaps the most significant adverse event. And I'm going to stop there by giving you a whistle-stop tour why I think that guidelines, in some cases, we need to be cautious in interpreting what led on to that guidelines and how we should use our personalized approach in individual cases. Thank you.